Town Hall for Healthcare Professionals, your platform where we meet every fortnight to talk about healthcare in Cameroon, a platform that brings about healthcare experts from different parts of the world, all who are Cameroonians. And we have on our platform medical doctors, lab technicians, nurses, public health scientists, all that you can imagine, community healthcare workers. So we meet here every fortnight to share conversation on specific topics that we think is of interest of our people back home. As of course, today we are going to be moderating the session with other co-moderators. I can see Louisa Viban is on set. Louisa, good morning.
Good morning, Elvis, and good afternoon, good evening to everyone. Nice to see you all.
Great. It's a pleasure seeing you, Louisa.
Pleasure all mine.
Christelle is here with us. Bonjour, Christelle.
Bonjour, bonsoir, bon après-midi à chacun et bienvenue à cette nouvelle édition de Cameroon Town Hall.
Thank you very much, Christelle. And do we have Brian yet? We're still expecting Brian and of course, Alison. And here is Mono, our chair. Mono, nice to see you.
Yeah, Elvis, thank you very much. And I'm very excited for today. And I just want to thank everyone who comes in and logs in every 2 weeks for us to try to improve the healthcare system of Cameroon by educating ourselves.
That's great. And it's been some time we've not been having updates on the COVID. Mono, what can you say about mixing of vaccines?
So I think we are safe mixing vaccines. The data proves that vaccines can be mixed at this moment, especially data coming out from the UK. I did not do any updates today because the topic is so important. And I think in the next 2 weeks, we may revisit COVID. So AstraZeneca mixing with Moderna and mixing with Pfizer also has shown very great, almost similar levels of immunity. So I think mixing vaccine is safe at the moment from the data we're having.
That's very great. And in Cameroon, what is it that we can mix in Cameroon?
This is in Cameroon, I think all the AstraZeneca and the Sputnik all have the same technology, and the efficacy have been shown they can be mixed. If there's one is not available, but there is really no advantage mixing them. And Johnson & Johnson, those who took Johnson & Johnson and want to get a booster dose, if it comes now, it's FDA approved in the US as of, I think 2 days ago. So you could get the Johnson & Johnson as a booster once you got the AstraZeneca and the Sputnik. So it's just a matter of weighing your risk and seeing exactly how things go. But I think we'll revisit this topic about mixing. Is a big thing going on. Those who took AstraZeneca before coming to the US or who have migrated. I have a friend who called me, the mom was from Ethiopia. She took AstraZeneca and now they are giving boosters, and he's asking, can the mother actually receive Pfizer? The UK is the only one that provides us with very good data on that. That shows that those who took Pfizer after getting AstraZeneca also mounted a high level of immunity. So you just put me on the spot, Elvis.
And you are always ready. If you, who else? If not you, who else? Thank you so much. And Christelle, of course, vous êtes au Cameroun. Depuis votre rentrée au Cameroun, qu'est-ce que vous pouvez dire par rapport à l'accès au vaccin d'abord et les collègues, votre collègue, les médecins, les infirmières qui sont vaccinés? Quelle est votre impression sur l'acceptation ou l'adoption du vaccin COVID-19?
Elvis, bon là tu me mets sur le hotspot apparemment comme Dr. Foma, mais ce que je peux dire, c'est que ce que j'ai remarqué, c'est à l'arrivée qu'il n'y avait pas assez de vaccins, il y avait une rupture de vaccins dans certains sites, donc on a pris la première dose, mais ne pouvait pas avoir la deuxième dose. Maintenant, les collègues sont toujours hésitants à recevoir le vaccin, il y a des études qui l'ont montré jusqu'ici. Donc, je crois que la communication qui continue et que l'on fait aussi sur cette plateforme pourra aider à convaincre bon nombre d'entre eux. Mais je crois que oui, c'est la situation là maintenant et toute autre personne sur le terrain, dans les hôpitaux pourrait commenter en plus. Ce serait un plus. Merci.
Merci beaucoup, Christelle. Thank you very much. And we wanted to just set the stage for our own expert for today, Dr. Lekubo Allen. Welcome, nice to see you, sir. And I want to thank you so much for accepting our invitation on the Cameroon Town Hall for Healthcare Professionals. We know how busy your schedule is, and we know it's not been easy to get you to sit here with us for 2 hours. And we want to really thank you so much for your availability.
My pleasure. Thank you too for having me.
Yeah, thank you so much for accepting to speak with us today. And of course, I'm going to tell you who our speaker today is. Dr. Alain Lekubo is a neurologist and public health science lecturer at the Pennsylvania State University with a dual training in epilepsy and stroke, both in Lyon, France from 2009 to 2013 in the Charleston, South Carolina University in the United States of America. That was from 2013 to 2019. He also completed a master's in clinical research at the Medical University of South Carolina. Dr. Alain Lekubo medically and surgically manages epilepsy and takes care of patients with acute ischemic stroke. His research goal is to improve the understanding of factors influencing the incidence and outcome of stroke and epilepsy and the link between both conditions. To date, he has published more than 70 peer-reviewed articles, including a top-tier stroke and epilepsy in very top-tier stroke and epilepsy journals. So his research focuses primarily on developing models to improve post-stroke prediction and the impact of seizures on stroke survivors. So Dr. Lekubo is an assistant professor of neurology and public health sciences at the Penn State College of Medicine here in the United States of America. It's really great to have you, and we know you've also passed back in Cameroon. Thank you so much for accepting to be with us today. And I turn over to you for the presentation on stroke, or what we need to know. Thank you.
Thank you. Let me share my screen first. I hope I will do this successfully, right?
Yeah, so Elvis, before you start, I want to add, Dr. Lekubo is an internist. I know he never says that. He's an internist who was trained and back in Cameroon, and he actually influenced a lot of our careers. I worked with him back in Bamenda when he was a general practitioner before he went for his residency in internal medicine. And a lot of us here, myself, Dr. J. Basil, Dr. Taka, we are all part of his products that he actually created. We admired him, we loved him. He was the best internal medicine resident we ever saw with knowledge beyond imagination. So I'm always pleased to invite Dr. Lekubo, who is an elder brother to me and a wonderful physician and also a wonderful teacher. So Dr. Lekubo, please, you have the floor.
And to say also, I collaborated with him at Unite for Health Foundation in Cameroon when we just started at Meta Quarters. I'm sure you can remember.
yeah, I remember Meta Quarters. Thank you, Elvis.
All right.
Thank you, Dr. Former. And really, I'm really excited to be here with you guys. And I hope we have a very thoughtful and also very inspiring session. So I will spend the first 45 minutes, have an hour, an hour to go over a couple of slides. So I don't want us to stay focused on the slides. I really want us to get the message, and I will really make an effort to get my message through. So this talk is mostly to sort of increase awareness on stroke and let people know that we can do something against stroke. And I want to first thank everybody here for taking the time out of their very busy schedule to make it this afternoon or tonight. And I also want to thank Dr. Former and the whole team for finally giving me this opportunity to sort of bridge with my colleagues back home and to pay back what they've invested in me. So I'm really excited about this, and I couldn't hide my excitation when I heard that Dr. Former contacted me to give this talk. So without further ado, let's dive into the topic. So my objective for this talk quadruple. First, I hope that by the end of this talk, we can all be familiar with the updates in stroke prevention, acute management, and some rehabilitation too. I also understand the gaps and challenges in applying current international guidelines to resource limited setting as far as stroke is concerned. And I also hope that we can, through this discussion, foster innovative approaches to stroke care in resource limited settings, including Cameroon. And finally, we all have to pave the way to improving stroke care in resource limited setting, including Cameroon. I'd like to start by telling you a story. This is the story of myself, a story of my friend. I have a friend, a very close friend of mine. We grew up together. We were in Cameroon. We were playing soccer, I would say almost every day after school. I went a different direction and I moved to the States. And then I met my friend a couple of years later. It was a real friend. When I say a friend, believe me, that's an understatement. We did everything together. We ate together. There was no single event that I would attend without my friend next to me. Then my friend called me and said, "Hey, you know what, Alain?" He calls me Alain. I said, "You know what, Alain? I went to my doctor today, and my doctor today, and I was told that my blood pressure was high. My weight was out of whack. I couldn't breathe, and my cholesterol numbers were really through the roof." And he was almost tearing and asked me what to do. And I was very concerned about that, more concerned than he was. And not only because he was my friend, but I was concerned because I have seen what people of his age, he was in his early 40s, mid 40s, of his age have endured, have suffered because of this, of being overweight, because of having high blood pressure, because of having high cholesterol. Thankful he wasn't a smoker, but he had enough to have what I keep seeing every day in my practice. So let me share with you guys this case, which I believe is going to illustrate my concern for my friend, which I will call Zin. So this is a case that is real, a case that I just came across a few weeks ago when I was on call. I cover acute stroke calls for several hospitals where I live. So this is the case of Mr. JH, a 46-year-old left-handed man with hypertension, hyperlipidemia, and type 2 diabetes mellitus. He had no recent surgery or bleeding, was last seen normal at 9:30 a.m. on the day of admission. Mr. JH came in with acute onset trouble speaking, left facial weakness, arm and leg weakness. He was brought by EMS and came to the hospital just 30 minutes after symptoms onset. On exam, he had a mixed aphasia, meaning that he couldn't speak clearly and he couldn't understand what we were saying clearly. The left side was weak. He has a left hemiparesis and the left visual field cut. His NIH stroke scale was 7. For those who are not familiar with NIH stroke scale, this is the scale that tells us how severe the stroke is. And it goes from 0 to 42. 42 is the maximum. Above 25 is considered a major stroke. So 7 was a moderate stroke, but severe enough given the aphasia and given the trouble seen on the left side, which I call left visual field cut. His blood pressure was 198/88 millimeter of mercury. Heart rate was 78. His weight was 94 kilograms, just for a height of 160. So he was clearly obese. His BGL, blood glucose, was 81 mg per décilitre. Donc, c'est le cas ici d'un jeune homme de 46 ans qui a tous les facteurs de risque classiques d'accidents vasculaires cérébraux et qui vient avec un déficit moteur du bras gauche, de la jambe gauche, du visage et a des troubles de l'élocution. Donc, son NIH stroke scale est 7, donc le score d'AVC est à 7. Un accident vasculaire cérébral qui est considéré comme modéré, mais suffisamment préoccupant parce qu'il a des troubles d'élocution, qui est une fonction qui est vitale et qu'il est incapable de voir du côté gauche. At this point, I would like you guys to just give me just give me a sense of what you will have done. So there's going to be a sort of a question for you guys. So what is the single next step to order? Okay, so if you were to take care of this patient, what would you do next? Donc, si vous étiez aux urgences et que ce patient venait à votre rencontre, quel test lui proposeriez-vous dans l'immédiat? Vous avez le choix entre l'électrocardiogramme, une tomographie cérébrale avec angioscanner cérébral, qui est simplement un examen qui permet de voir les vaisseaux du cerveau, ou alors une radiographie du crâne, ou alors, et fait une dernière possibilité, vous ne ferez rien du tout. En tout cas, le patient, on n'a rien à lui offrir. Dr. Mono?
Yes, so I launched
okay, perfect. Thank you.
I launched the poll. They can answer question 1 and 2 for now.
Question 1
Question 1 was how many people in the audience and have taken care of stroke patients?
Excellent. Thank you. You guys need more time to answer, or are we good?
Let's give them more time.
All right, sir. Thank you.
Hello. Apparently, we can't submit without answering the 3.
Okay, submit. Answer all 3.
Okay, let's wait until we get to the 3rd one. Then we are going to have an answer for the 3. Okay. So you guys keep your answers, and then when you get to the 3rd question, you can just submit all the 3 answers. How about that?
Okay, good.
Is that deal? Okay. Thank you. I'm going to okay. So let's move forward. So I know you guys can correct your answers. That's fine. Okay. It's not about who knows, doesn't it? It's just about what your practice is, basically, right? So this patient got a CT. How I can move this of the head. That showed it. This is just one slice. Okay, but basically, believe me or not, believe me, this patient had no acute findings on the CT of the head. Okay, so the CT was normal. So le scanner cérébral sans éjection était normal. Donc, nous avons dans le centre où ce patient a été vu la possibilité d'effectuer un angioscanner cérébral en urgence. On n'en a pas toujours besoin dans l'immédiat, d'accord, pour la prise en charge d'accidents vasculaires cérébraux. Donc, il a bénéficié d'un angioscanner cérébral. So a CT angiogram head and neck was performed. And we showed this. And I want to spend a few minutes with you guys and describe what we see here. I think for those who cares for patients with stroke, it's important to at least spend a few seconds to describe what you see here. What we see here is it's a CT angiogram. So basically, we see on the right hand here, this is the right IC, the right internal carotid artery. Part of the intracranial portion and then the extracranial portion as well. And the left side is the left internal carotid artery. And in the back, you can see the big artery that supplies the back of the brain with blood coming from the vertebral artery on the right side and one on the left side. So what I just focus on what is abnormal on this scanner here. If you look carefully, you see that you can follow through this right internal carotid artery here and into the middle cerebral artery, and then there's a stop here, nothing after this. Unlike the left side where you can follow through and then you can still continue to see blood flow through the branches of the middle cerebral arteries, M2 and then M3 and so forth. And you see that they have more blood vessels on the left side as compared to the right side, some collaterals here. So bottom line, there was a stop, there was a left MCA occlusion here. So there's a blood clot here that you can see on these slides here. Okay, so knowing that the patient came with these symptoms and all the information that you've got so far, what will be your next intervention? You give aspirin, 3 to 5 milligrams, or you give aspirin and clopidogrel, those are antiplatelet agents, or you give an IV tissue, IV TPA, which is a clot buster, or you give IV TPA and mechanical thrombectomy, or you lower the blood pressure below 184 or 110, and you maintain it below 185 or 180 or 105. Then you give IV TPA and mechanical thrombectomy, or you do nothing. Again, we are in a situation where we have access to all the technology. What would you do?
So please, you can now answer all 3 questions. Please, you have a minute. There is no wrong answers.
Exactly. This is just to see what people think, right? Not what they know.
So I'm going to give another 30 seconds, then I will stop and then I will share the results for the poll. Okay, so I'm going to share the results. I think looking at the results, we can see from the results, Dr. Lukubu, about in our audience, about 36% of them do take care of stroke patients. And about 36% also are not involved in direct patient care. Then we have 100% of them are going to order a CT scan of the head. And what is the next intervention? It's split between all the options.
Okay.
But the highest percentage goes to lower blood pressure below 180/110, then intravenous tissue, plasminogen activator, and mechanical thrombectomy.
Perfect. Thank you.
Which is 36%. So
Thank
I'll
you.
stop sharing.
All right. Excellent. So what that does tell us is, and I'm going to get to what we did, right? So we do things because we follow guidelines. What that means is that people sat down, the big guys, they look at studies, and then they came out with recommendations on how to actually manage ischemic stroke. And these are the most recent one. And so for this, I'm just going to focus on two things here, and then I will share with you what we did for this patient. And we are going to reflect personally on what we on our answers. So for the IVTPA, the intravenous thrombolytic, and the IVTP, for the IVTPA, the thrombolytic agent, clearly there is a benefit when patients are seen below 3 hours, within 3 hours window of symptom onset. Okay, when they are seen between 3 and 4.5, there's still some benefits. But this study, the recommendations are don't include patient age 80-year-old, those with prior stroke, and diabetes, or those in an age of 25 or higher. So and beyond 6 hours, I mean below 6 hours, between 4.5 hours and 6 hours, there is clearly there's some benefit, but there's a risk of death and intracerebral hemorrhage. So bottom line, we in our practice TPA to patients who come to the hospital within 4.5 hours of symptom onset. So time is brain. That's from the guidelines. Now, I want to emphasize something that the FDA has not approved IVTP. The FDA is the drug administration in the US that basically monitor how drugs are, drug safety and administration in the US. So the FDA hasn't given its approval for 3 to 4.5 hours window period, even though we do it, okay? And then for mechanical thrombectomy, we also have data to support that. And data come from basically 5 major clinical trials. The first one was conducted in the Netherlands, Mr. Clean trial. The name really doesn't matter. So really what matters, and I want to share that with you on this slide, is that when patients receive mechanical thrombectomy, which basically is using a device that and then navigate through the brain arteries and suck out the clot. So open up the clot basically. When you do that technology, when you do that procedure, which is very simple in the hands of people who are trained to do that, and you can be trained to do that as few as 4 or 3 years after your residency. So what happens is that when you use thrombectomy in blue here versus usual care, there is a benefit in terms of how where you're able to function. So the MRS, which is the modified Rankin scale, is a scale that tells people, that helps us neurologists and those involved in patients in stroke patients care, that tells us how functional the patient will be after the stroke. 0 to 2 is considered a good functional outcome. When you have 3 and above, it's considered to be a poor functional outcome. 6, you are deaf, basically. And 5, you are bedridden. You can't do anything without any help from people around you. So if someone receives mechanical thrombectomy, it has a 44% chance of becoming independent, all right, at least at 3 months, as opposed to 31% if you just get a usual care. Same for MRS of 0 to 1, and again for MRS between 0 and 3. Mortality, we can't reinterpret this data, so forget about it. There was a trend, but it wasn't significant. And there's one important part of this graph that I want to show you is the one at the top right corner. We show the number needed to treat. In other words, when you see patients with acute ischemic stroke and you offer them thrombectomy, if you treat 7 patients, all right, if you treat 7 patients, then one of the patients will be functionally independent after 3 months. And if you decide to use 3 as a cutoff point, if you use 2, you need to treat 8 patients. If you use 1, we need to treat 9 patients. So basically, you have to invest in 7, 8, or 9 patients to be able to get a benefit from the procedure. So these are just 2 elements of the acute stroke management, but it's not all, it's more than that. I just want people to be aware that there are things that can be done acutely. We don't just sit down there and wait for people to develop their deficit. There are things that can be done in some cases, and those cases are selected very carefully. Now let's go back to our patient, Mr. JH. So Mr. JH, this is what we did, and now you guys can compare this result to our management to what you guys have chosen in the polls. So we gave him 10 mg of IV nicardipine, so lowest blood pressure below to above 140/78, and then we gave him 9 mg of IV TPA as a bolus, and then the rest was given as an infusion over an hour. That's what we typically do. And the next day's NIH was 3, so his stroke was less severe. Remember, the NIH stroke scale is that scale of stroke severity from 0 to 42. 0, you have 0 deficit. 42, you are, this is the maximum. So this patient was towards the lower end of the spectrum with an NIH of 3, just 3. Facial droop, some word find difficult, and left arm drift, liver drift. Okay, so we did, I would say, pretty well. And again, remember, the benefits are maximum after 3 months, and sometimes after even past 3 months. So we expect that this number will probably go down, even though we don't use the NIH stroke scale after 3 months. We use a different scale, which is the functional scale, the MRS, the modified Rankin scale. Donc, sorry. And then the patient CTA, the computer tomographic angiography, the computer tomography angiography, which is the dye test, showed a right carotid stenosis 80%. We kept an NPO, nothing per mouth. We talked to speech pathology. We had him on DVT, had an echocardiogram, telemetry was put in place, his rhythm was normal. And look at these numbers here. LDL was 140, and his A1C was 8.9%. So remember, this patient came with blood pressure of 194 for the systolic. LDL through the roof. A1C through the roof. A1C, for those who are not familiar with A1C, that's a number that tells how well your diabetes is controlled. 6.5% is around the cutoff point where we want to be at. We want to be below 6.5%. He was at almost 9%. So clearly, his blood pressure wasn't controlled. His LDL cholesterol his dyslipidemia wasn't controlled. His diabetes was not controlled. And he has this right ICA stenosis. Donc, ce patient a finalement bénéficié de perfusion intraveineuse de nicardipine pour baisser la pression artérielle en dessous des valeurs indiquées dans les recommandations internationales, au moins américaines. Et donc, il a reçu également un traitement thrombolytique par voie intraveineuse, et son score d'AVC a baissé de 7 à 3. Il avait encore quelques déficits, mais qui, avec le temps, nous l'espérons, vont s'améliorer. Et chose importante, l'angioscanner a révélé une sténose serrée de l'artère carotide interne droite. Et les chiffres de la glycémie et de la lipidémie étaient anormaux. Donc, ce qui veut dire que pour ce patient, oui, nous avons proposé un traitement pour la prise en charge en aigu. Nous avons aidé ce patient à retrouver une partie des fonctions qu'il avait brutalement perdues. Mais est-ce que ça s'arrête là? Est-ce que l'on va dire, OK, monsieur GH, votre bras est capable de bouger un tout petit peu, vous pouvez parler mieux, votre visage est moins déformé, alors c'est bon, vous rentrez à la maison? Non. Our job is not done until we make sure that Mr. JH doesn't come back here with a different, another stroke. Okay. What does that mean? That means that we'll have to take care of his rehabilitation, right? Physical therapy, occupational therapy, speech pathology, and more importantly, we have to make sure that we work really, really hard to prevent a second another stroke from happening. So we have to fix JH numbers. cholesterol, blood pressure, diabetes, and weight, okay? And we have to clean these arteries. That's when the vascular surgeon will come into play and try to go and do an ICA and a right endarterectomy, which is a procedure that consists in opening the artery and cleaning that up and covering and close the artery again to allow blood to flow freely in that right carotid artery. Of course, we need more social engagement and support for Mr. JH, who probably will need, we certainly will need people around him to support him. And also, we need to be engaged more socially. Okay, so this is what happened acutely. Okay, now, we may wonder if the same thing would have happened to Mr. JH if he was in Cameroon. Sometimes people say, oh, ça c'est l'affaire des Blancs, hein? Ça c'est l'affaire des là-bas en Amérique, right? Which simply means, okay, we don't see this in Cameroon. We don't see stroke. It doesn't happen to us. Well, I would argue that this is, I hate to say this, to tell someone that is wrong, but this is incorrect, okay? Why is it incorrect? Because it's incorrect because we share the same risk factors as people in the US, and sometimes it could be even worse than what we see here. I don't want people to focus on the numbers here, but I want people to be aware that the same risk factor, the same thing that brought Mr. JH to the hospital are also present in Cameroon, and worse, people are not aware of that, and they are not properly treated. It's no one's fault, it's our fault. Okay, so I took this number from this diagram from Dr. Andre Pascal Kenyan and Professor Andre Pascal Kenyan and Professor Banya. That was a study that they did back in 2020, 2012, including about 2,000 patients. It was a community-based study, population-based study, so a really solid study. And what it came out with that is that they follow patients prospectively between 1994 and 2003. So the study was published in 2012. So, but data were collected before then. This is like 20 years back. Think about it. Things have gotten worse today, I can guarantee you. So basically, blood pressure has increased. Okay, this is for so blood pressure. This is rural here, rural, and this is urban here. So let's just focus on this one here. The same thing, the same trend was observed everywhere else. So the dashed lines are women, and the continuous line are I think they say should have been men. No, this is it's a mistake here. Anyway, bottom line is I think it was mislabeled. When you look at the blood pressure, what happened between between 1994 here, which is the dashed line here, okay, then the continuous line, sorry, and 2003, the dashed line here. So if you place your arrow here and you go all the way up here, the percentage was around 70% for in 2003, but you see that there's a shift in the line here. Okay, in 1994, the percentage was actually lower here. So there's an issue with colors in this diagram, but the bottom line is that blood pressure is prevalent in Cameroon. 30% of patients in Cameroon people in Cameroon have high blood pressure, and 1 in 4 men are not aware of the blood pressure. 2 in 5 men are not aware of their blood pressure. Okay, and we know that having obesity, being old, and having a family of high blood pressure actually increases the risk of developing high blood pressure. So high blood pressure is prevalent in Cameroon. It's something that we see all the time. What about other risk factors? Look at what happened. Diabetes, 6%, 8%, and 80% are underdiagnosed. Obesity, 30%, and hyperlipidemia. These numbers, we can argue about these numbers, around 2%, and then smoking, 5 to 11%. These are among college students. So what this tells us is that we have risk factors for stroke, but we may not be, we are not aware of these risk factors. And worse than that, there's a recent meta-analysis that showed that the level of awareness actually is dropping. Number one. Number two, the level of blood pressure and all those risk factors control is not doing any better. And not surprisingly, we have this number for stroke. So this is this data come from the global burden of stroke by Dr. Fagin. So what this paper shows us is that when you want to red, the more you are red, the worse you are basically. If you want to be blue, so the incidence is low. Look at where you are. almost red, right? Orange. So the incidence rate in Cameroon, the incidence rate of stroke in Kenya is around 160 per 100,000 people. These are just estimates. I believe this is the tip of the iceberg. We probably see more stroke than what these numbers seem to convey. Okay, so la prévalence, l'incidence des AVC au Cameroun est certainement plus élevée que ce que l'on peut imaginer. On ne voit que la partie visible de l'iceberg. Donc, il y a des cas d'AVC au Cameroun qui passent simplement sous les radars. Et l'une des explications, c'est que l'accès aux soins n'est pas uniformisé. Et les patients qui ont des AVC pourraient se retrouver dans d'autres structures que les structures classiques sanitaires. Et les patients qui ont des AVC qui sont minimes, qui ne sont pas suffisamment graves, ne pourraient pas se présenter à l'hôpital et donc ne pas être pris en compte dans les statistiques. And we did something, I would say, not original, but something that I would always be proud of. Back in the 2012, we look at registries in Hôpital Central Yaoundé, and trust me, it can be difficult to conduct study and research in Cameroon. But I believe that if you are hardworking, if you are a strong believer, you're a go-getter, you can get out with some interesting and important results. And that's what we did. This wasn't a perfect study. It was just retrospective. We look at data between 1999 and 2012. And we tried to see, to look at the proportion of patients with a diagnosis of stroke across those 12 years. Well, we went from 2.5% of stroke admission due to stroke to 13.1% in just 12 years. Okay. Again, these are hospital data. You can argue that this is probably this data confounded that we didn't account for. But what this tells us is that there's something brewing underneath. Okay, there's something happening, and then we don't see that at the surface. And I have a mentor who always says that what happens in the hospital determines what will happen in the community. So what we see in the hospital probably is a reflection of what is happening in the community. Stroke is in Cameroon, and it's not going to go away if we don't do anything. Okay, that's why we must, and we can prevent stroke. We can do it. We can do it. Trust, believe me, we can do it. We can close this tab. Okay, there are just too many strokes for us to take care of. But if you get to a level where we can go upstream and lower those stroke risk factors and lower the incidence, the new stroke, and the new stroke cases, then we can be left with a number that our healthcare system can substantially manage. And that's where I believe the money is. That's where you need to put the money. And I'm so excited to tell you that it is possible. It is possible because we've seen things happen. I'll let you know why in a few minutes. Let's take a look at these numbers, and this is very important. I will tell you, this is very important, right? For several reasons. Number one, before we go into we go through the slide. Number one, remember our population is young. So between 15-year-old and 65-year-old, I mean, we have about 60. I believe 55% of Cameroonians are aged 15 to 60-year-old. So we have a young population. And we know now that if you have a low physical activity and hypertension, just those two, okay, are the most important risk factor, accounting for all of them together, almost 80% of all strokes. What that means is that if you are able to just focus on the 55% of Cameroonian age, in that age group, probably a little bit higher than that, and then make sure that they don't have high blood pressure. Okay, this is idealistic, right? This is really like a dream, but it's possible. Okay, it's possible. If you can make sure that no one in that age has high blood pressure, no one stays home and don't exercise, you may expect to lower the rate of stroke by somewhere around 50%, right? Let's be a little bit more conservative. Is that possible? Yes. Is that reality? Not yet. Are we going to get there? Maybe. Can we get there? Yes. Okay. And coming back to my friend Zin, so when Zin called me and I said, hey, Alain, I need to talk to you about my health. I'm like, okay, you know what, Zin, I love you. No, you're my friend, you're my buddy. I can't live without you. We've been away from each other for some time, but I think we remain the same guy, the same buddy that we used to be when we were young. And I told him, you are only 44. I mean, you're in your mid 40s, early 40s. So this is your time for you to take care of yourself. And you can make it. Just pay attention to what you eat. Just really make time to exercise, and you will see things happen, right? Donc j'ai dit à mon ami Zin, je lui ai dit, Zin, tu sais, tu es jeune. Tu n'as même pas 45 ans. J'ai vu les jeunes de ton âge faire des AVC parce qu'ils étaient obèses comme toi. Ils étaient hypertendus comme toi. Ils avaient des chiffres de cholestérol élevés comme toi. Et leur glycémie était un tout petit peu élevée, 150. Et ils ont fait des AVC. Et rends-toi compte, Zin, rends-toi compte. Si tu es capable de ramener tes chiffres à la normale, tu vas réduire ton risque d'avoir un accident vasculaire cérébral. That's what I told you. I told him, if you can bring your numbers within normal range, you could lower your risk. Of course, you could still have a stroke. But if I was able to duplicate Zin and say, okay, I'm going to make 100 Zins, and I'm going to follow up the 100 Zins prospectively. If all the Zins lower their blood pressure to a normal range, if they lower their BMI, the body mass index, which tells you how obese they are, if they lower their cholesterol, they can lower their risk of stroke by 80%, meaning that just 20 out of the 100 Zins will end up developing stroke. That's amazing. That's just so exciting that Zin started working out. And what happened to Zin is that in 2018, Zin was 210 pounds, which is about 94 kilograms. His blood pressure was 140 over 98 millimeters of mercury. His blood glucose was 148. His LDL cholesterol was 102, and the HDL, the good cholesterol, was just 38. Then Zin, as he promised to me, as my buddy, as my best friend, he started taking care of himself. And to the point where now, 3 years down the road, Zin is down to 165 pounds, which is a normal BMI 44, sorry. His blood pressure is like a baby's blood pressure. His glucose is like, it doesn't really, 74. His cholesterol, LDL is down, half of what it was before. And his HDL just went up. So Zin has made a commitment to lower his stroke risk. Of course, Zin can still have a stroke, but remember, out of 100 Zins, just 20 of them may still have a stroke. Okay. So preventing stroke is good, right? We have to make an effort. Should be personal, can be within a big number of programs, national programs, to lower the risk of stroke by addressing those stroke risk factors. So we can lower the rate of stroke by addressing those stroke risk factors. But I want to say something. You may disagree with me or agree with me, but this is my belief, and this belief is supported by evidence. We need stroke units in Cameroon. It is vital. We should stop, and I say should. I didn't say can. I didn't say must. We should and must stop flying blind. There's no way you can fly an Airbus 380 without a cockpit, without a pilot, without a crew. We need a place where people need to sit down. Specialists need to sit down. Okay, there will be physicians, nurses, social worker, dietitian, occupational therapists, support staff, and all that you can imagine around the patient in the stroke unit. So that stroke unit will be a geographical, well-defined area in the hospital where people take care only take care of stroke. So this is a very dedicated area in hospital where people spend their time taking care of stroke. Well, is it possible to have such a unit in Cameroon? Yes. Should we have all these people around the patient with stroke? To begin with, it's difficult. I would say it's almost impossible at this stage. But you have to start somewhere. When you were born, at first you were able to walk. Then you started crawling. Then you started walking, you were falling. Then you started walking more steadily. You started running. So you start somewhere, and then you gradually walk your way up, and you make things bigger. If we start, which is possible, with a team of people in a particular area in the hospital, you start doing that, taking care of patients with stroke just in that area, with people who spend their day breathing and eating stroke, just doing stroke. The amount of expertise that those people will get after a few months, years would be tremendous. That would be a laboratory for people to come, sit down, discuss, talk about stroke, do stroke research. We don't need big money to do research. We don't need people to start doing things. They will be experts, and they will serve as an example for people around them, for other hospitals. And more importantly, there will be a shiny light for patients to see and say, hey, we can do something for stroke. There are people there who just spend their days taking care of stroke. It's something serious. And ultimately, when people see that you are organized, they want to help. If you are not organized, no one will come and put his money in. They work hard to get that money, so they want to make sure that when they invest the money, there's a return on investment. Not for them, but for the community where the money goes to. So if you organize, people will come and put their money in. They will invest, and you can be part of an international consortium. You'll be part of clinical trials. Money will keep pouring in, and your patient will keep getting better. So we have to start somewhere. We have to start building those stroke units. We don't need 20,000. We only need one to start with, and we need that model to shine and show to the people around that it is possible. And then it saves life. And it saves life. It really saves life. I will tell you why. This is a study that was conducted in the US in the late 20th century. And back then, remember TPA wasn't, remember TPA, the thrombectomy, really wasn't so popular, right? So these are people who were, I would say, not exactly the same situation as we are in, but they shared some commonalities with our healthcare system in terms of not having that particular treatment, the clotbuster or the thrombectomy, which, by the way, just came in 2015. So what you can see on this slide is that you have three groups here, okay? And this is a serious study, very serious one. So the top line are those in the stroke unit, okay? The middle one are those who are at home, and then they're cared by physicians. So they stay home with a stroke, and then people come and take care of them at home. And the last one is people in hospitals, and there's a stroke team coming and visiting them. So basically, what is happening in Cameroon? So you have people they are scared in hospitals, and then you have a doctor, a neurologist, and some nurse, some medical students or residents. They come and say, "Oh, you had a stroke. Okay, this is what we can give to you, right?" Then the way to read this line is this is the survival here, right? The higher the number, the better. Okay, so one means that 100% of people survive after this amount of time. Okay, so what this clearly demonstrates is that being a stroke unit save life, and you don't need to have TPA or thrombectomy. You just need to be in a place where people are dedicated days and nights to take care of stroke patients. Similarly, in terms of functional deficit, when you look at patients who are seen in the unit, the stroke unit versus those seen by the team, or the unit versus domiciliary, those seen at home, again, in terms of ranking scale, okay, between 0 and 3, it was significant. The difference was there. So not only stroke units save life, but they also improve functional outcome. Donc, les unités de soins neurovasculaires sont capitales. Je dirais c'est la plaque tournante, c'est le pivot de la prise en charge des AVC au Cameroun. Les hommes ont besoin d'une lumière, hommes et femmes ont besoin d'une lumière, d'un prisme à travers lequel ils voient les patients qui ont souffert d'un AVC être pris en charge. Cela augmente la confiance au système, cela augmente la confiance aux médecins, au personnel médical qui prend en charge ces patients-là. Et ça augmente l'adhérence à la prise en charge, l'adhérence l'adhérence au traitement préventif des accidents vasculaires cérébraux. Ça permet également que l'AVC soit pris au sérieux par les décideurs. Ça permet également que le Cameroun puisse briller sur le plan international. Et je le dis sérieusement parce que si nous avons des accidents des unités de soins neurovasculaires qui fonctionnent, pas forcément comme c'est le cas dans les pays occidentaux, mais qui fonctionnent avec un minimum de personnel et qui font des choses qui sont louables, les gens seront prêts à y mettre de l'argent, à y investir, pas pour eux, mais pour la communauté. Ils sont nombreux d'ailleurs qui n'attendent que ça. Ils veulent les gens organisés, travailleurs sérieux pour y mettre de leur argent. Et au final, de la même façon que nous sommes connus pour le sport, pour le football, le soccer, les gens diront, écoutez, là-bas en Afrique centrale, au Cameroun, ils ont des unités de soins neurovasculaires. Nous avons cette étude sur les AVC. Allons vers eux et voyons ce qu'on peut leur offrir. Donc, les UNV, les unités neurovasculaires, sont importantes dans la prise en charge des accidents vasculaires cérébraux dans notre contexte. Okay, so far, we've talked about what happened in terms of prevention. We've seen how those stroke risk factors were prevalent in Cameroon and were going up with probably a lower awareness and lower control. We saw how the stroke numbers were probably going up, okay? We saw that it is possible to prevent stroke. It is also possible to take care of stroke patients once they have a stroke, but this should be done in stroke units. Now, of course, we try to close the tap, right? We try to lower those numbers, but still there will be patients with stroke, patients who will remain with deficit. What about them? So we should be prepared for after stroke. You had a stroke. Okay. Sorry. I think I'm not sure what happened. I lost my last slide. You guys still there?
Yes, we
are there.
I'm not sure what happened. But okay. Anyway, that was my last slide. So basically, what I was saying is that we need to shift paradigm now. There's no time for us to say, okay, we just going to focus on prevention or on acute stroke management. There's time to care for patients for stroke survivors. And caring for them will mean that we have to make sure that we fix their numbers. You have to make sure that they don't have another stroke. We also have to make sure that, oh, here we go. Okay, I think I'm back. Can you guys see this? No.
Yes, I shared your last slide. Okay,
all right, you're a genius. I forgot about that, sorry. So here's the thing. So there's what we call a tripod. This tripod is important, right? But they're not as important. I mean, the level of importance is probably different across the board. But really, they are all important. We need that primary stroke prevention. We take away that, the rest will suffer. We have the means to prevent stroke, and this can happen through different ways. Okay, we can discuss that later on. We need to have a stroke unit, or stroke units, I would say. And to me, this is pivotal. Without that, we will continue to fly blind. We'll be in the dark. People need to see that stroke is real and it's taken care of by people who are trained to take care of stroke. And once we have a stroke, we still have hope for you to prevent another stroke and for you to get back to where you were before. Okay. It is our responsibilities, not physicians. When I say our, say as Cameroonians, to all together put our hands together and work towards decreasing the burden of stroke. It is possible, and I believe that all of us can contribute to this goal of zero stroke, right? I say zero stroke. Yeah, zero stroke. Yes, let's aim for the star, and then follow on the moon. Thank you, guys. Have a good day.
Wow, thank you so much, Dr. Lekobu, for that. I can see like the chat was on fire. Everyone is hot.
I know. I couldn't follow. I was just focused on my talk, but that's impressive. So you're moderating. Okay, you go ahead and okay.
Yeah, so we just wanted to check the temperature of the house first of all. I see that our other co-hosts are here, Brian and Allison. I just want to check how you guys are doing. Like we didn't hear from you at the beginning, and now we're getting from you when everyone is high. So can you just like turn on your mics and let us know how you feel? Brian, start with you.
Thanks, Lisa. I joined a little bit late. I'm not in the best position to talk right now. But I really appreciated the great overview of the incidents. I was struck by that incidence graph that you shared on just the overall burden of stroke across the globe. And I saw really particularly the African region really being highlighted in red, and just being the paucity of data that we're also seeing from other countries across the world. That was really pretty striking. Thanks a lot, Dr. Lekobu, for really very insightful presentation.
Thank you. Yeah, let the moderator speak, right? Louisa and Christelle, Dr. Foma.
Allison, you can go ahead.
Oh yeah, thanks, Lisa. Hi, everyone. It's such a pleasure to be here. Apologies for joining late. I had competing priorities. However, I was able to pick up on the Kaplan-Meier curves that Dr. Lekobu shared with us, showing higher survival rates among stroke patients within hospital settings. And I found that to be really thrilling. And I think that's important information. And it got me thinking, as someone who has parents who are obviously at high risk for various reasons because of their age and other existing comorbidities, looking at how their care could be handled within the Cameroon setting. It really got me thinking. And also just reflecting that in the past, when our parents have these conditions, like, whether it's hypertension or diabetes, and you're telling them, listen, you need to take your medications, they take it for granted. Then when they go to the hospital to visit a friend who has had a stroke, when they come back, you usually see a change. Suddenly they realize, oh, well, this thing is really serious. So, having them in a hospital care obviously improves the quality of care that the stroke patients would get, but it also shows the gravity and the severity of the condition that they have. And I think it also helps to raise awareness among their peers and in the community. So Dr. Lekobu, thanks so much for this amazing presentation.
You're welcome. You're welcome. And just welcome too.
All right, so we're going to start with questions, and we know, Dr. Lekobu, we understand that you're time bound, so we're going to keep it really straight to the point and short.
I'll follow my pager. Don't worry, I'll follow my pager to someone until 3 p.m. So I'm covered.
All right, thank you. Thank you so much for that. Okay, so I'll start by giving the floor to our chair to give a comment, and then if he has any questions, he can go ahead.
Oh yeah. So my hand was up maybe the first because I have a practical question for Dr. Lekobu, which I think he's going to be able to answer it. If he was made minister, Elvis usually asks this question. If he was made Minister of Health today in Cameroon and has a budget we know quite well right now that we are unable to safely give TPA to patients. I use the word safely because some hospitals do give it. We are unable to provide a CT scan as the first assessment in most regions in Cameroon, and in most districts do not have it. We are unable to we are not even dreaming about mechanical thrombectomy at this time. And what are you going to put your emphasis on if you're given a budget to invest on stroke in Cameroon right now, which is limited? Like, our resources are very limited. And I know your talk was very practical. That's what struck me about your talk. But I want to know where, as an expert, you're a public health physician, You are an internist, you are a neurologist, you are a stroke specialist and an epileptologist, but where are you going to invest? Are you going to think about this as a stroke specialist or as a public health physician, and where would the budget go to? That's just my first question.
Okay. Can I answer that one first? Maybe before. Can I answer that one first? There's an echo. I'm sure what is it. Can you guys hear me? Okay, perfect. Okay, good. Right. I think one key message is that you as an individual, you cannot take care of stroke in Cameroon. If I was minister, I will make sure that I get experts around me to discuss that question. You need clinicians, you need public health specialists, you need nutritionists, you need everyone to sit down and say, okay, where do we put the money and how do we move forward to lower stroke burden in Cameroon? Being a minister is just, I mean, don't get me wrong, it's an administrative position. And really what you need are people around you, the experts, to guide you make the right decision. Now, I am biased because I'm a clinician first, okay? I see patients with stroke and I have that bias I'm compassionate. When you ask me to speak about stroke, I always think about my patient. I always think about the last one I saw die in hospital, having not be able to speak. I always think about that 30-year-old woman with a 3-year-old boy, son, who is no more able to speak. So that compassionate aspect of myself is probably going to bias my decision. Okay. Now, if you want to think about someone who doesn't see patients, okay, and I'm a public health specialist. I sit in my office, I look at numbers, I do what they call the salary sur le terrain, right? Dr. Elvis, and then I look at the community, I look at the numbers, and I make decisions, right? I'm not always there when things happen. I look at the graph, the figures, okay, it's getting better, it's getting worse. I'll probably say, okay, let's put emphasis on prevention. If I now put myself in the shoes of someone who has a parent who has suffered from stroke and is at home, not be able to care for himself, I'll have a different view. So all this to say that really everything is important. And it is a challenge to say that you're going to put money, invest money in this or that. But what I can tell you is that we need a fundamental change in culture. And that change, this is my opinion, right? You can agree, you can disagree, that's fine. We need to be in a situation where we can take care of ourselves first. We don't have to wait for the government. Yes, the government is just going to help us, yes. But let me ask you this question, Dr. Mono. You are in your, I believe, late 30s, early 40s, right?
Yes.
How many times do you wake up in the morning at 5 a.m. and say, today, whether it rains, snows, or whatever, I will run for 45 minutes on the treadmill or outside? You only need okay, number one, what do you need the government to be able to say, okay, I will try and not eat junk food today? You don't need that. Okay. Yeah, here's where the government comes into play in this situation. The government will say, okay, we're going to regulate how much salt we put in food, whatsoever. We are going to make sure that we build a what they call a sport complex in each neighborhood. We can do that, right? So we don't need the government to make things happen. Sure, they will help. Sure, they will bring money, but how that money will be used will depend on people who actually are going to benefit from that money. It's not only about money; it's about a cultural change. Donc c'est un changement profond culturel qui nous interpelle. Je n'ai pas besoin, pour partir du marché d'Eido à Bepanda, de monter sur le Ben Sekin. Je n'ai pas besoin, pour aller à l'école de Bepanda, à l'école publique d'Eido, pour ceux qui connaissent le Cameroun, je n'en ai pas besoin pour décider d'aller à pied et de parcourir 1 kilomètre chaque matin, 1 kilomètre chaque soir. Je n'ai pas besoin de ça. C'est vrai que le gouvernement a sa place, a son rôle à jouer. Je n'en disconviens pas. Mais il faut un changement culturel profond. Je n'ai pas besoin de manger, excusez-moi, du port et boire de la bière au Carrefour chaque soir pour démontrer que mon statut, mon standard, mon niveau de vie s'est amélioré. Et c'est ça que nous oublions. On pense que c'est en buvant des bières et en mangeant du porc qu'on a progressé. Non. Quand on mangeait du beignet à l'école étant étudiant, on mangeait bien. On mangeait du bunga avec du riz, on mangeait bien. C'était un changement culturel. On allait à l'école, à la fac, on faisait 2 km chaque matin pour la fac et 2 km pour la fac. On était en bonne santé. Je dis c'est un changement culturel. Qu'on le veuille ou pas, que vous soyez d'accord avec moi ou pas, ce changement culturel, il est primordial et il vient avant que le gouvernement n'intervienne. Voilà. That's my opinion, right? It's not, I mean, you may or may disagree with me, that's fine.
Yeah, and I love your opinion because it gives responsibility to everybody in this change, gives us the responsibility to be able to do something. So I'll leave the floor for the moderators. There are several hands that are up, please.
Thank you, Dr. Foma. Thank you again, Dr. Lukubu. Oh, I have switched into English. Merci beaucoup pour la présentation une fois de plus. Et nous avons quelques questions déjà dans le chat et aussi des mains.
Okay.
Je vais commencer, si vous permettez, par la question qui est dans le chat. Elle est de Brice Sawa. Great things are moving on in Cameroon with the availability of scan. Do you have a strategy, knowing the rarity of specialists in the field, on where start a stroke unit? On where to start a stroke unit? Bon, désolé, c'était un chat privé.
Okay, so should I answer that question? Or it's a private question there? So
no, je crois que c'était
let's make it public. Let's make it public, right? So the question is, where will I start a stroke unit in Cameroon? Is that what the question is about?
Yes, Doc.
If I were to start a stroke unit, where would I start with, right?
Since we don't have it since we don't have scan available everywhere.
I think if you look at and I'm sure if I show you the basic stroke unit organization, you really want to have you need a hospital. That's the bottom line. Okay. So I'm not talking about the ideal stroke unit. We need a place that is geographically defined for managing stroke patients. And only, I would say we need people who spend their time, or most of their time spending taking care of stroke patients. So you need that geographic area. So first you need a hospital. You won't go to a place where there's no hospital, period. Okay. Number two, you need the place where they can diagnose stroke. What do you need? Someone with strength to diagnose stroke could be a GP, could be an internist, could be a nurse, could be anyone who is equipped with the tools to diagnose stroke. And what I mean tools, is your clinical judgment first. Stroke is a clinical diagnosis, and that is confirmed by imaging. That doesn't mean that we don't need imaging, right? If you miss stroke, you always catch up anyway. So you have stroke, and you have the area, you have the people who can diagnose stroke and take care of stroke after that. And you need a place where you can get a CT head, if possible. Ideally, in some places the standard, it's the minimum. It's the minimum, but you have to do with what you have in hand. You can still take care of patients with suspected stroke and do well. Ideally, when you have a stroke, that makes a huge difference between those with bleed versus ischemic stroke versus subpulmonary hemorrhage. Then you need people who will be able to say, okay, this patient is safe to swallow. This patient should start moving his legs or his arms. That's physical therapist, okay? Good. And then you need people who come and say, okay, we need to talk to the patient and help him speak more fluently. So it's a big team. So really, you want to have that ideally and I will put, this is my opinion, you want to have that in a teaching hospital, okay? In a teaching hospital, that's where most of these people are more likely to be found. And that's where you will have medical students, residents rotate and spend 1 month, 2 months just caring for stroke patients and get the knowledge that we need. And that knowledge will be taken away from there and spread to the community, to other hospitals. So we need people to come and see, touch, practice and go with that knowledge somewhere else. And where that happens is in academic centers. Am I answering your question?
Brice?
Yes.
Okay. Okay, thank you, Doc. Can we please call for Jutwin Zo to come in, and please can you present yourself so that we know who you are and where you are dialing from before you ask your question. Thank you once more.
Hello, everyone. I'm Judwin. I'm a pediatrician in the UK. I'm also a public health practitioner, even though I'm a little bit idle at the time, but I've got an interest in public health nutrition, which is what I got my master's in. So I thought it was a very interesting presentation. I made some comments in the chat box, which I'm going to discuss. So I mean, listening to Doc talk, right, especially with the last question where someone asked what you can do for Cameroon, and he said a lot about having tertiary centers, for example, using level 2 kind of, but even our level 2 kind of centers in Cameroon are not equipped to even diagnose clinically a stroke, or even talk less of imaging, because I believe that for us to be able to diagnose these things, we need to already be aware. So, and to be aware and have protocols in place to enable the rapid diagnosis and initiation of treatment. And so it feels like it's a death sentence already for a lot of people in Cameroon, especially because we have lack of access to imaging. So my belief is that focusing on preventative care is really, primary care is really important. So primary prevention, sorry. And I think, okay, so Dr. Muno asked the question to Doc is, about the role, I can't remember what he asked, the Doc was answering towards the role of individuals in their own care and the government. And Doc focused, Muno asked him about the role of government. And he said, actually, it starts with the individual. I feel like, as someone who mentors and motivates people a lot towards getting fit, eating healthy, and stuff like that, I believe that, and living in the UK, where a lot more is done from a public health point of view to prevent cardiovascular disease compared to the US. I give examples. So things like having good public transport systems, having which encourage people to walk more than drive, having good safe roads which have like cycling lanes. So where I work, for example, a good chunk of us cycle to work, for example. How would you tell someone in Cameroon to cycle to work, for example, or someone in the US where places are really far away from each other, or I'm not sure how well the lanes are, the roads are, for example, cycling and stuff. Things like imposing sugar tax, which is the UK recently introduced, I think last year or a couple of years ago, where sugary foods have a higher price now, just as a means to discourage people from consuming them more. And things like reducing portion sizes. So if you go to the US, everybody knows that portion sizes are way large compared to like the UK or Europe, where the size and content of food is different. So yes, we can all say it's up to the individual. And I always tell people you have 160 or so hours a week, and you only need about 25 minutes of that as regular. If you're doing vigorous activities such as running, but or 150 minutes of moderate, which is a tiny fraction of the activity of your time. So if you think about it, that's 15 minutes 3 times a week of activity. I'm someone who works out. I work out 4 or 5 times a week. Like, it's just part of my lifestyle. And I walk to work. I take the lead. I park away from work. I walk to work. I cycle to work because I change jobs all the time. If my workplace is within 5 minutes, I cycle to work. So yes, you have the individual motivation, but that's for literate people. That's for people who know. So if you're talking about somebody whose priority is trying to eat, for example, then thinking about his cardiovascular health, something that is an invisible disease, is not something that people see until it affects them and it's too late. So I think that focusing on preventative care is very important. And in places where, even in Europe, in the West, in the US, you need governments to be involved. If governments are not like super involved in trying to get communities active, eating healthy, then it's just going to be, we don't have that primary component, and then it's always going to be getting it to the stroke level, to the secondary and to tertiary unit. So I think that the government has a huge, huge role to play in preventing cardiovascular disease in general. Thank you.
Thank you. Thank you for your comments. I think it was more a comment than a question, right? I don't have to
Indeed.
answer to.
Thank
I don't
you.
have to answer to this.
Yeah, it was more of a comment. Yeah.
Thank
More
you
a
so
comment.
much.
Thank you.
Thank you so much. If I may just summarize, I think the government has a role to play, but we have to play a major role up front. Is start with the individual, the family, the community, and then the government. That's what I can say. If you work for the government, I'm afraid we saw the numbers here in 2003. It's going up. They're not going to do anything. I'm sorry to say that. We know that. Let's not fool ourselves. It's not that they will try the best they can, but it comes down. It all drill down to us, to me, if I can say that. Sorry, I have a different view, but that's my my little opinion. They will do something. They will help. For sure they will help, but they are slow in taking it in motion. Slow, very slow in motion, and sometimes the goals are different. They have so many competing issues. I mean, think about it. You're sitting there, you are ruling a country. You have to take care of people's health. Within health, you have stroke, diabetes, you have HIV, you have cancer, and then you have to take care of your borders, security, right? Education. All those aspects, that's the government. So people are sitting there waiting for the government to come and save them. I can tell you, I'm not an administrator, but they are sometimes overwhelmed. And with those competing issues, it's hard for someone to say, okay, we're just going to focus on cardiovascular diseases. We have to advocate for that. We should keep advocating for that. But while waiting for things to happen, we have to individually start looking at ourselves, looking at our friends, our best friend, and say, hey, it's time to change. It's time to take care of yourself, with or without a government, with or without road, with or without sidewalks, with or without sport complexes. We have to do something. You woke up at 5 a.m. I'm not trying to teach anyone. We're all adults here. I'm not trying to teach anyone what to do, okay? But really, it's a call for action, and that action starts with us in our house. That's my opinion, okay? I mean, I can be wrong, and I don't have to agree with everyone.
Thank you very much for the reaction, Dr. Lekabo. We're going to give the floor to Dr. Agbo. Sharon. So if you can just read, like we have your question on the chat, but if you could just ask your question, we'll appreciate. Thank you.
Okay, I hope, sorry, I don't have my video on. I hope I still remember the question. So I'm Dr. Terence Agbo. I'm a clinical biochemist. I'm also assistant clinical professor in lab medicine in University of Alberta, Edmonton. So I had two questions. One was a cheeky one, but I will go to the more serious one. So the more serious one is you showed some epidemiological data there. So you have those sites which are red and a lot of some few blues here and there. In those countries which are blue, which are of course based on your data and the information you give, there is a decreased risk of stroke. And my understanding is that in those countries, most of them do have national screening guidelines for diabetes and cardiovascular disease and dyslipidemias. And usually this is followed up by education. And going to one of the conclusions, the major conclusions you had in your presentation, which I love so much, is that your friend presented you with high lipid values and glucose and A1C values. You advise him to for exercise, and eventually he lost weight. He now looks very skinny, which decreases the risk. So would implementation of this kind of screening guidelines, I don't know, maybe it, you have to forgive me if they do exist in Cameroon, but if they don't, would implementation of this kind of screening guidelines and follow-up education help to promote this kind of preventive measures? Because if someone screens, and like I believe it was Dr. Jodwin who mentioned about exercise, and the most common comment always made in all diabetes guidelines is that, and lipid guidelines is that 30 minutes exercise, 3 times a week actually helps. If people do screening, this kind of screening, and follow up with things like education and lifestyle modification, would this not help? Would this be one of the most important strategies to decrease the risk of stroke and other cardiovascular disease even before they develop? And then the second question, which is the cheeky one, is that you showed you are in one of your pie chart there, I believe there was the group of individuals to look after your stroke patients. One of the things which I didn't see there is how will you follow up your patients? What part of your group will follow up your patients? Especially, I realized that you also mentioned in your presentation that you would look at the lipid values, the glucose values, the A1C values. I didn't see the laboratory is there. As an advocate of laboratory medicine, I think that was a big miss.
Thank you, Dr. Abo. I agree with you about the big miss that you mentioned, laboratory, of course. This is a model. No model is perfect, and I truly appreciate that you were able to bring that up. Okay, thank you. Now coming to your question about screening, clearly, there are clear data on the other field that have shown that screening it's a useful tool to prevent and manage diseases. You take it, across the board, it works. Now the question is, how do you measure that for stroke? Okay, you have you screen for diabetes, and then your endpoint is how many stroke they end up having. You screen for hypertension, you end up and asking yourself how many stroke those who are screened end up having versus those who are not screened. So I think the endpoint is a little bit, alone itself is hard. We have to have a composite endpoint to really see the effects of those screening. And sure, screening works. There's more involved in screening, as we know. And how many people are you going to screen? There are so many conditions out there. And I keep saying that we need to screen, for sure. We need to do all this. Stroke is like a big elephant, right? You try to move that elephant forward. And to do that, you need multiple efforts from multiple stakeholders. Screening will help, but let's not be fooled by the fact that screening will just all of a sudden make stroke disappear from Cameroon. So
excuse me, no. Yeah, I agree. That's not what I'm saying. I'm saying this is what I think. And of course, it's composite. But I think that if you screen for diabetes, you screen for dyslipidemias and people who are presenting with high triglyceride and high cholesterol, especially LDL cholesterol, then, of course, I'm not a clinician, but I know sometimes for some of the patients, for people who are cardiovascular disease expert here, there's introduction of you start them on statins. This will decrease the risk of developing most cardiovascular disease, or even lifestyle modification. Like, okay, you start exercising. There are people who don't exercise, who think big stomachs are a measure of affluenza. And then if you do a screen and show them, yeah, these are your lipid results, this is your sugar, this is your A1C, you need to modify your lifestyle. I mean, you can't screen everyone, but for most screening guidelines, they recommend that for people, around men, women greater than 40 years, you have to do screening maybe for all some of these diseases, like 2 or 3 times a year. At least if that could be implemented and done periodically, everyone will not be, it will not be possible to do it for everybody, but that will also be a starting point.
Yeah, I fully agree. That's certainly an avenue to explore, and which probably certainly will lead to increase awareness and possibly better control, because not of their risk factors. That I fully agree. We come down to primary prevention, right? I fully agree. That's certainly a tool in our toolbox to use to try and prevent stroke in Cameroon. Fully agree. Thank you.
Thank you.
All right.
Thank you, Doc.
All
yeah,
right,
go ahead,
sorry.
Lisa.
I was just going to say that thank you for quenching the fires of Dr. Zoe and Dr. T, because once you started your presentation, they were like taken up and really part of the conversation, and they kept on commenting with every
It is
slide
really
that you
exciting
made.
to be here. Really. I wasn't expecting to be that interesting.
Yeah, so thank you,
Yeah.
Dr. Nzo and Dr. Akpo for the contributions.
Thank you, guys. Very nice.
So, Christelle, you can take over.
Yeah. Merci encore, Louisa. Merci, Dr. Lekoubou.
Okay.
Ce que nous avons remarqué, c'est qu'au début de la présentation, on était à peine une vingtaine. Et au fur et à mesure de la présentation, vu l'importance et l'actualité du sujet, nous avons pratiquement le double des participants. Et nous voulons ici appeler Dr. Bill. Dr. Bill nous a quittés. OK. En attendant que Dr. Bill revienne, nous avons des questions dans le chat. Monsieur Christian Pout, merci d'insister sur cette question de responsabilité individuelle en plus de l'interpellation de l'État. Mais selon vous, quelle solidarité pourrait être mise en place pour renforcer les compétences en formation initiale et continue du corps médical local, évidemment pour la prise en charge de l'AVC?
Is that Dr. Christian Pout? This is a very, very good friend of mine, by the way. We went to the same high school. Very smart guys, I can tell you. Very humble too. Anyway, thanks for your question, Dr. Christian Pout. Je vais répondre en français. Je vais essayer de répondre en français. J'espère trouver les mots justes pour exprimer ma pensée. Voilà. Ce que nous faisons aujourd'hui à travers Cameroun Town Hall, c'est déjà, à mon avis, un pas vers cette solidarité-là. Et je pense qu'à l'ère du numérique, c'est la voie à emprunter. Nous sommes capables de développer des compétences, même à distance. J'entends souvent les gens dire... Is that what's happened? Okay. So j'entends souvent des gens dire que parle de fuite de cerveau. Ce n'est pas l'objet de la question, mais c'est juste pour dire qu'à distance, des personnes qui ont eu la chance, l'opportunité de se frotter à ce qui se passe ailleurs. Pas forcément parce qu'ils sont plus brillants ou non, simplement ils ont eu l'opportunité, je le dis bien, l'opportunité de se frotter à un système qui est différent, qui est plus performant que celui qu'ils ont laissé d'où ils viennent. Ces personnes-là ont acquis des compétences au fil des mois, des années. Donc, qu'ils puissent partager ces compétences, qu'ils puissent faire en bénéficier aux autres, la meilleure voie, l'une des voies, à mon avis, c'est à travers ces échanges qu'ils ont avec les personnes restées au pays. Ces échanges peuvent être faits de façon formelle, à travers des débats comme celui-ci. Ces échanges peuvent se faire à travers des études de cas. Ça veut dire que moi, je fais de la téléneurologie, par exemple. Je vois des patients à des milliers de kilomètres d'où je vis. Pourquoi ne pas penser à un système comme celui-là, où peut-être périodiquement, nous pouvons, avec les collègues sur place, discuter en live, en direct, des dossiers difficiles. Ça va bénéficier du patient. Le patient va en bénéficier dans l'immédiat. Imaginez une situation où chaque semaine, vous avez un cas difficile dont vous parlez, dont vous discutez avec des collègues. Après 1 an, ça fait 52 cas. Après 2 ans, 100 cas. Donc, vous êtes en train comme ça de construire, de développer des compétences. You are building capacities. Et c'est ce que l'on veut, développer des compétences. Je ne crois pas à un miracle qui viendra des personnes qui sont à l'étranger et qui sont dans un système qui est mieux organisé, qu'ils rentrent au Cameroun et s'asseyent et commencent à faire voir les patients. Donc, ça ne marche pas comme ça. Vous avez besoin de créer un pipeline où les gens vont être formés à prendre en charge, dans le cas des AVC, les accidents vasculaires cérébraux. Et c'est pour ça que j'ai insisté si lourdement sur l'aspect, sur le rôle majeur des unités neurovasculaires. Ça ressemble à rien, mais je peux vous dire, sans un endroit comme celui de la physique, où les gens peuvent effectivement voir les patients couchés, hémiplégiques, aphasiques, des patients qui sont ataxiques, qui n'arrivent pas à bouger un côté du corps de façon smoothly. Okay. Quand vous avez ces unités comme cela. Quand vous avez à côté des gens qui regardent un scanner cérébral et disent, ah, mais tiens, c'est la tête cérébrale qui est OK, qui est probablement obstruée ici. Quand vous avez l'infirmier, la nurse qui est là et qui vous dit, non, ce patient ne peut pas manger maintenant parce qu'il est à risque de faire des fausses fautes. Quand vous avez un jeune monsieur qui a 20 ans, très solide et qui fait des massages aux patients, toutes ces personnes-là en un seul endroit, ça va créer une dynamique remarquable qui va permettre donc que les gens à partir de là maintenant puissent se dire, OK, nous avons ça, nous manquons de ça. Nous avons Dr. LXY à Kousseri, à Yaoundé, dans le cas qui était là à Kousseri. Nous avons Dr. Mouno, Dr. Foma aux États-Unis, qui sait faire dans tel domaine. Mais posons-nous la question, tout ça, ça va faire en sorte que l'unité neurovasculaire puisse être ce laboratoire-là qui permet la collaboration entre les locaux et ceux qui sont à l'étranger, et même entre les locaux. Donc, on a besoin, et j'insiste dessus, on a besoin de bâtir ce réseau. Et ce réseau, les points du réseau, ce sont les unités neurovasculaires et les webs, c'est-à-dire, comment dire ça, les points les points de liaison entre les unités neurovasculaires et l'étranger vont s'établir naturellement. On commence par là, on est organisé, on sait ce que l'on fait, et ensuite on bénéficie amplement des compétences de l'étranger, des compétences locales, et on devient des experts. J'espère répondre à la question du docteur Pout.
J'espère aussi que le Dr. Pout a été satisfait par votre réponse. Merci encore. Et dans le chat, nous avons une autre question de Kimonia, que je vais résumer en français. Sa question concerne notamment la prise en charge de l'AVC quand le malade se présente soit tardivement, soit parce que l'accès au scanner n'est pas possible pour des raisons soit d'insécurité, soit de scanner non fonctionnel. Qu'est-ce que vous pouvez recommander pour la prise en charge des patients dans ce cas?
Okay, this is $1 billion question. Okay, good. So should I answer in French or English? I mean, first of all, so the question was in English, French. I mean, it doesn't matter, right? It really doesn't matter at this point, right?
Maybe the answer in English?
Yeah, I don't know.
Since it was in English.
Okay, so should I mean, I don't want to sound like disrespectful to the guys who asked the question. If he really feels that I should go ahead and add. Okay, thank you, Yvette. All right, here's the thing. I think the big question is where I am. Am I in Balachi? Am I in Yaoundé? Am I in Ezeka? What are the tools at my disposal at the time when I see the patient? So, and that brings us to developing local guidelines. Local doesn't mean that they are underrated. No, it simply means that they are adapted to what we have in hand. Meanwhile, we're working hard to making progress and getting to where other people are, right? So if I'm not able to get a CT of the head or head CT, I believe I'm able to speak, to talk, to touch a patient, to use my brain, okay, and to examine the patient and finally come to a diagnosis of possible stroke. There are stroke mimics. I'm not going to go into the detail what stroke mimics are. Because I spoke to the patient, I know there was an acute onset of a focal aphasia, focal weakness and aphasia. And the patient has diabetes, has high blood pressure, which are uncontrolled. I know this is probably a stroke, but the big challenge is it an ischemic or hemorrhagic stroke? And I can't answer that question without a CT of the head. So that's a big limitation to account for, a major one. And it's even a major one because we don't, the numbers, if you look at the prevalence of ischemic stroke versus hemorrhagic stroke in Cameroon is probably lower. What I mean by that is that we probably have more ischemic stroke in the US than in Cameroon. So we still see a lot of patients with hemorrhagic stroke in Cameroon. And the reason is very simple, high blood pressure. Don't go and look for any magical reason. High blood pressure is uncontrolled high blood pressure, right? So that's a big limitation. I don't know whether this is ischemic or hemorrhagic, but I know a few things that can make things different. I know if this patient has a stroke, first thing, we need to examine him. Second thing, he need to be in the hospital. Third, we need to make sure that he can safely swallow. We need to mobilize the patient as soon as we can. That's important. And then his blood pressure numbers need to be cautiously managed. We know that this patient needs at least to have some basic workup. Okay, this is acute phase. Acute phase, that's what it is, right? Once you're done with that, or while you're doing that, you're preparing the patient to go back to the community if possible, or to recover. And you're making sure the patient doesn't have another stroke when leaves the hospital, if he's able to make it. And you are doing that by making sure that you can at least get his blood pressure. You don't need any money for that. You get the handcuff, period. Okay, the blood pressure cuff, period. You need to get the patient glucose or A1C if possible. LDL cholesterol, I heard that the lipid panel is about 10,000 in Cameroon. It's still doable for most people, right? We can still do that. We can still get those numbers and then fix those numbers. So there's even a call for shifting the paradigm in terms of stroke management. You know, we used to focus on acute stroke management, thrombectomy, TPA. TPA, by the way, which costs about $7,000, which is about $3,500,000 from Cameroon. Just that one vial of the IV clot buster, right? So there's a paradigm shift that is needed here, from caring for just acute stroke or prevention to caring for patients who've had a stroke. We need to build that. It's not that we're throwing our hands and say, okay, we had a stroke. There's nothing we can do against stroke. So just to come back to your question, we need to, in the acute phase, with that CT head, really keep the patient safe and try to make sure that the patient doesn't develop those complications that are related to stroke at this stage. And then once that stage has passed, we need to make sure the patient can safely go home and then prevent him from having another stroke. I'm pretty sure that even if it wasn't possible for that patient to have a CT scan on the day he had a stroke, and I have data to support that, most patients will end up having a CT. If it wasn't possible for that patient to have a CT of the head at the time he was seen for the stroke acutely, most patients down the road end up having a head CT because families just mobilize around him and they make sure they can make money, get money to buy, to pay for a CT of the head. Once you have a CT of the head, you can now determine if it was ischemic or hemorrhagic, and that will help you refine your secondary prevention in that case. I want to say something about TPA, and I know that's not the question. You said there were no CT head available, but I believe that more patients now, at least in those big, large academic centers, can get a CT head within 24 hours. More patients are able to get that CT head within 24 hours. And the hope and the good news, I should say, is that if you are able to obtain a head CT on a patient with a suspected minor stroke or a TIA, a transient ischemic attack, a mini stroke that go away, okay, or should I go away? Let's put it this way. If you can do that within 24 hours, if you're able to get a CT and determine that that stroke, that mini stroke is ischemic, meaning that it's due to a blockage in the artery, one of the arteries in the brain. If you can determine that, there are very simple and cost-effective, and I would say affordable medications, which you can now use to lower their risk of, to improve their functional outcome, meaning that they'll be able to move again or to speak again more so that they hadn't received those medications. Aspirin and Plavix, I believe, are widely available in Cameroon, and we know that by giving aspirin and Plavix to patients within 24 hours of a minor stroke, improve outcome. It's simple, it's cheap, it's affordable. And again, I want to insist that if we had stroke units in Cameroon, it doesn't have to happen everywhere at the same time. It has to start somewhere. If you happen to be in a stroke unit in Cameroon, you had a stroke, and then you will be more likely to receive that therapy because people know about, so they eat stroke, they breathe, so they know stroke like very in detail. So we want people who are scared to manage stroke and should stop flying blind and pretend we know and pretend she maîtrise and she maîtrise. What do you know about stroke? I'm sorry to say that we have to sit down and learn and do things properly, and that will happen in the neurovascular unit, the stroke unit. Thank you.
Merci beaucoup, beaucoup, Doc. Merci infiniment. Chairman, tu veux bien dire quelque chose?
I had a question, so I'm trying to get questions also answered. So it's just going back into acute stroke management in Cameroon. I just want to ask Dr. Lekubo, he knows Cameroon very well. He's one of the few people who have worked both at the regional level, worked at the central level in all the teaching hospitals during his training as an internal medicine resident, as an internist in Cameroon, worked in France and worked back in the US. So do you think at this moment we are capable, even if we have, are we capable of safely administering TPA to our patients? Are we capable of giving thrombectomies, of doing thrombectomies if we get to a point where let's say L'Hôpital Central is apt to want to do mechanical thrombectomy? Is it a procedure that you think with the plateau technique right now, can we improve that level, the plateau technique, to be able to do this kind of care? And is it necessary based on the public health impact of carrying out that kind of expensive procedure in order to save a life? I will just give you a story before I continue, which reflects the difference between healthcare in the US and in the UK. My mom had a stroke, which I never really talked about to others. My mom had a stroke in 2008, where she was in the UK visiting, and I spoke to the doctors there then. Then in the US, mechanical thrombectomy was standard of care, but in the UK, it was not. She had a middle cerebral artery stroke. And they gave her TPA, but did not do mechanical thrombectomy, which till date, I still want to sue, kind of. But it gets to the point where it's true that depending on where you are, your level of care could be different. So do you think at the moment, should we strive towards improving technology to save one life? Or should we strive towards, it's my mother, so I advocated for that, but I know exactly what it takes to do mechanical thrombectomy and all the plateau technique and everyone that gets involved, and depends on which hospital they go to. Or should we strive for public health measures that are going to improve the life of thousands? What is your take on it? It's just a philosophical question, really. I know there's no true good answer.
Okay, I'm glad you mentioned that it was a philosophical question. Really, you have to think about, are you thinking about the individual, or are you thinking about the society and so on? If you are in a social group, right, family, whatever, and you look at the individual next to you, the rapport that you have with that person is different than if you were away from that group and just watching and trying to say, okay, overall, those people, there are 10,000 people out there, I'm going to try to save the life of, let's say, 100 of them. That's different. Okay. If you have to reconcile both, I think what you have to do is to take care of the individual and then look at the whole group. The whole group is public health. You got to do something for them. You got to prevent, you got to lower the blood pressure number by 1 millimeter for the whole population and lower the stroke risk by 4% in stroke survivors, for instance, right? But your mom who had a stroke, you want to make sure that if she has a recurrent stroke, she can go somewhere where she can be assessed thoroughly and get the right treatment, which may imply that she gets another TPA or thrombectomy this time. Okay, this is now comes into play money. Where do you have the finances to do that? And that's why when people blame the government, I always say, okay, I'm not, yeah, you can blame the government, but those guys, they have a lot to do. Sometimes some of them don't care, so to say that, right? Or they don't really feel what you're paying, whatever you can take and say. It's easy to blame the government and say, oh, okay, they don't do enough. But do they have enough money to do what they're supposed to do? Is there an oversight on what they're doing? Thrombectomy in Cameroon is that something that is necessary? Human beings, Cameroonians are human beings. Cameroonians are exposed to stroke. Cameroonians have stroke. The answer is yes. Is TPA something that can be given in Cameroon, should be given in Cameroon? Again, there are human beings. They have heart, they have feelings. There are families. I don't want to see my mom die of a stroke when I know she could have been given something that could have saved her life. Yes, the answer is yes. Should we prevent stroke? The answer is yes. Now, can we at this, or to this, can we today safely provide those therapies to people in Cameroon? We know very well that patients who got TPA in a well-organized system, they do better. They do better because you have people, it's like driving, right? If you drive 100 miles every day, you are more skilled than someone who drive 5 miles every month. In other words, the more you give TPA, the more you see stroke patients, the more you are likely to do the right thing. If you work in an environment where people will say, okay, have an eye on you and have to give you a feedback on what you're doing, you are more likely to do the right thing. If you are trained to do something, trained the right way, you are more likely to do that thing. Are there doctors in Cameroon who are trained to give TPA? The answer is yes. I moved to the state. I moved to the state after completing my training in France. I was able to give TPA and to know when to do thrombectomy. So there are people in Cameroon who have the training for that. But the individual alone is not enough. You need to have a system in place that will allow them to, first of all, perform what they've learned and also keep their learning throughout. And keeping them is not magic. It's doing it every day. If you go back and then you don't give TPA for 10 years, you forget about it, I can tell you. Okay, so we can give it, we can give it, but we need to make sure that this happens in a safe environment. The environment matters here. Am I answering your question, Dr.?
Yes, you answered my question. And the question was, as I told you, was a philosophical question for us to reflect.
Okay.
That what you're talking about can be done and should be also advocated for patients, because
it should be. It should be. It starts somewhere. I will start somewhere. That's my
stroke. The thing about stroke, which I wanted to say in addition to that, is that it leaves you, there are diseases that kill you, but stroke at times leaves the mortality and morbidity of stroke is extraordinary, which is going to go to my follow-up question. What's the place of physical therapy in the management of stroke, especially in the context of Cameroon, where training physical therapists is not even part of a lot of the curriculum back home? We have very little physical therapists that are available, and we don't even tend to see the importance of it. It's just a follow-up, and I'm done. Moderators, I'm sorry. So.
We need stroke units, period. I'm sorry to say that, we need stroke units. Let's stop flying blind. Get all the patients in one place, people will say, Jesus had to make miracles for people to believe in him. We need to make miracles in stroke units and people believe in us.
Thank you so much. Dr. Foma, you got me laughing. All right, Dr. Bill, if you're available, please can you ask your question now? Sorry we missed you earlier.
Thank you very much.
All right, you're welcome. Okay, you're here.
Yes, this is actually Dr. Wingo. Bill is my code name. I would like to thank Dr. Likubu for the very brilliant presentation. I would like to really recognize the fact that as a medical student, I worked under him in the regional hospital in Bamenda. And back then, nurses never loved to go for rounds with Dr. Likubu because it lasted the whole day. But of course, it was for a very important purpose, to transmit to us a lot of notions that have shaped my very little clinical career that I had before getting into public health. I therefore throw back myself into the clinical days to start and to find out already from Dr. Likubu what are the odds of having a full-blown ischemic stroke after a transient ischemic attack? And what more do we need to do after an episode of a transient ischemic attack that an ordinary individual who has never had one is supposed to do? Is there going to be any difference in the attitude that you're supposed to adopt? My next question is that physical therapy is very important for stroke management. One thing in the population is that they do not understand why it's important. But me, I would try to ask, how early should we start physical therapy after a stroke, be it hemorrhagic or be it ischemic? And for how long should this go on? I'm asking this question because I would like to educate the population on this, because most of them find it very long and they don't really get to understand what is the added value. Then from a public health point of view now, I will agree with you that neurological units are very important. But what about the rest of the population? Prevention is very important too. And that is why I keep on promoting the issue of multi-sectoral approach to healthcare delivery, especially in our less developed countries. We have to already embrace the notion of healthy cities and workplace health. Don't you feel that it's a bit neglected when we know that majority of the adult population find themselves in workplaces, not really majority per se. In Africa, many people are farmers, but a good proportion of our population, the active population, find themselves in workplaces. Why not advocate for healthy workplaces, healthy cities, cities that are designed, taking into consideration health exigencies? Today in our hospitals, they build hospitals, they don't invite anybody who has any notions of health, like they build hospitals. There's no airway movements that are adequately planned. Build cities, build roads, there's no pathway for people to run. So when we say people should modify their lifestyles, I think that we should not forget to advocate that cities should be built in a way that promote people actually doing exercise, because that is where the whole game lies, exercise. So thank you very much for your presentation again, and those were my few thoughts.
All right, thank you, Bill. Really interesting questions and comments. I'm not sure if I remember all the questions, but at least the first one was about TIA outcome. Is that correct? Transient ischemic attack outcome.
Yes, and
I tried to write down the question, but I think I missed something.
Transient ischemic attack.
Okay.
Yes,
okay.
and also having a full-blown stroke.
Yeah.
And then
Okay.
what to adopt to prevent a full-blown stroke after a TIA.
Perfect. I mean, TIA is very common, right? I can tell you that it's common. That's one thing. A TIA is a warning sign that something bad is going to happen, right? When you have a TIA, that's from one cohort in, I think it was Dr. Johnston in UCSF. Once you have a TIA, in the next 3 months, there is a 10% chance that you develop a full-blown stroke. And that risk is actually higher within the first few days. And that is why when someone has a TIA, he should not be sent home before being properly evaluated. So we had a chance to really catch the storm before the big storm, before, the tsunami. So once you have a TIA, that's a time for you to be properly evaluated so we can lower your risk of having another stroke. And how do we do that? We do that because we are able to, number one, identify your stroke risk factors. And we've seen all of them. I'm not going to go through all those risk factors. Number two, we now have the tools to know what the mechanisms of your stroke are. Think about it. You have the pump and you have the pipes. The pump is the heart and the pipes are the arteries that go into your brain. And anywhere between the pump and the pipe, you can have a clot that will form and that can move distally. And we know how to do that. And we know how to do that because we have anti-platelets and other more powerful blood thinners that we can safely provide the patient with, and which are going to lower his stroke risk. Think about it. If you are able to control just high blood pressure, diabetes, high cholesterol, you can lower and give someone aspirin, baby aspirin. you lower the risk of subsequent stroke by 75%. If you can lower the blood pressure by 1 millimeter at the population level, right? 1 millimeter of mercury, you can reduce the risk of having a second stroke by 4% and the risk of dying by 10%. And I said 1. Okay, so we have to focus on the risk factors and on trying to identify the cause of the transient ischemic attack. Your next was about stroke and environment, I think, right?
Exactly.
Clearly, I mean, there's a link between stroke and environment, and there's no doubt about air pollution, wherever you live, and your zip code determine how bad and how soon you can have a stroke. No doubt about that, and that's where the government needs to intervene. Okay, talking about the government. bidding what about is it Paco Vita? Paco Vita, I don't know where. I mean, you should make it clear that, for example, you cannot have a neighborhood within a Paco Vita 10 kilometers in the surrounding. Never. You can make it law. Make it a law. Period. Okay. How about the last one? I forgot the last one. Sorry about that.
The workplace.
Yeah, that's still the environment, right?
It's still environment.
Yeah.
Are there any particular interventions that you can propose to the heads of enterprises, big organizations, one or even government?
It's difficult. I think it starts with you. I mean, I'm sorry to say that again. It starts with us. I don't know whether there's any solution. It's probably not one that fit all. I'm not sure how much of the work environment really play around into stroke. But what I can say is that if you have a sedentary lifestyle, that will lead to obesity, high blood pressure, diabetes, and that's where maybe leaders can play a role and say, okay, you know what, we have you work from Monday to Thursday, so you have 4 days you can exercise, something like that, or you can work from 5 to 6 to 5, so that you can have time after 5 p.m. to go and enjoy life and go out and exercise, something like that. I mean, these are things that really need to come from individual companies, I would say. Okay. Am I answering your question, Bill? Sorry if I didn't.
Thank you. I think you're very right. I just feel that there are a lot of things that we neglect, little things that we neglect, and that count for a lot, because most of the time I try to link the diseases, the chronic diseases that they acquire as a result of the way their job sites are designed. People cannot work for 9 hours sitting on a computer and you expect them not to develop risk factors for cardiovascular diseases. So I think that
you can ask my friend Dr. Foma. He's a fellow now. He knows what.
No, I think we got the point. Thank you very much, Doc.
All right. Thank you, Dr. Wingo.
We can go on. I still have a few minutes. We can go on, and it's really interesting. Yeah, please.
How many more minutes do you have for
I don't know until they call me.
Okay, so we can give you additional 15 minutes for questions.
Yeah, something like that.
So Elvis is a timekeeper. He's going to get in. So there are more questions. Let's get 15 minutes before we round up.
Give me 1 second. I mean, sorry. You go ahead. Sorry. I need to. Sorry. Okay. Go ahead.
Okay, so we're just going to give the floor to Dr. Kate.
Yeah. Thank you so much, Louisa. And thank you so much for your presentation, Dr. Lekubo. Great to see you. And I'm sorry that I really got in just towards the end of your presentation. I might have missed a lot. And so I have a question, and I just want to, one question and one comment about what Dr. Foma and Dr. Wingo were mentioning around some of the public health issues. And my question is there anything one can do to reduce or to further reduce the residual risk that individuals may have for some of these cardiovascular events? Because after we might have done everything well and good, there is still some residual risk attached to every individual. And for example, if someone has had the previous stroke and he's diabetic and hypertensive and you're treating well, blood pressure is well controlled, sugar is well controlled, feeding is okay, that patient still has some residual risk, even is there any other thing now that there is evidence that points that can further reduce that residual risk? So that's my question. And my comment is just with regards to some of the things Owingo was saying about public health measures. I know in Cameroon that lately, I think that we've been trying to put together some of the governmental actions geared towards reducing, cardiovascular risk and, let me just say, non-communicable diseases in Cameroon. And when you say non-communicable diseases, you talk mainly of 4: cardiovascular diseases, diabetes, chronic respiratory pathologies, and of course, mental health issues and cancers. You can add that as well. So, and all of these pathologies have 4 main or 5 main risk factors, which are alcohol consumption, of course, physical activity to reduce sedentarity, of course, reducing blood sugar, and what else? And smoking, of course, which is main. And so lately, we're trying to write some documents that can help the government at the population level to actually reduce salt intake, things that what we now in public health now know as primordial prevention. So acting really at that policy level. And there's not been much that has been done so far, but these are some of the things that are actually ongoing and really trying to push the government to actually clamp down on some of the processed foods that are sold in the country with high salt content and high sugar content. But there's still much that has to be done. And so there's that kind of education that has to go at the population level, but also at the level of policymakers, that these things are important with regards to the burden of these non-communicable diseases and cardiovascular diseases that are actually hit our country. Now, environment, Dr. Owingo is right. You cannot go to Yaoundé, for example, and take a run or cycle in your quarters. How can you do that in Yaoundé? It's practically impossible. Usually, for example, if I'm abroad or, for example, in the UK, I'm very fit. By the time I go back to Cameroon, my waist circumference increases. So it's it's quite difficult.
I think that was a comment and also a question, right? A comment.
The first one was a question, and then the second one was just a general comment, adding to what Owingo and the former had mentioned.
I'm really thankful for the comments, which are going to enrich my knowledge on stroke prevention and particularly in Cameroon. Dr. G, sorry. So as far as those residual risk factors are concerned, I don't think anyone has the right answer to why they're happening. We see those patients with stroke, you do everything, they keep stroking, having strokes. And you don't seem to figure out why this is happening. And probably some of those factors are genetically determined. And we have some patients with inborn with hypercoagulability state, and which you don't know a lot until you screen them for those rare conditions. So those rare conditions are probably playing a role, and also some of the non-traditional risk factors that we don't always screen for. And we know that all the lipid molecules play different roles in stroke, including those that we don't typically test for in clinical practice. So it's probably going to be at the individual levels that actions will be taken into account the patient's age, the patient's genetic background, and also the patient's overall stroke aspect. What I mean by that is if someone has what we call embolic stroke of unknown source or undetermined source, that means that the MR of the patient CAT scan looks like you're pretty much sure that this is embolic, but you can't find a reason. This is different from someone with a lacuna, in fact, where the stroke is just deep in the brain and in the small. So 3 things: the genetics, the age, and then the stroke aspect may guide further refine and decrease the patient's stroke risk of recurrence.
All right, so thank you so much, Bukate, for the contributions. We'll give the floor over to Yvette, then we can wrap up after that.
Okay, thank you so much for giving me this opportunity, and I also want to thank the presenters for this. I'm sorry I logged in late, but what I want to say is more comments, not really questions.
Okay.
First, for the organization part, I just wanted to chip in. I don't know how the system back home is in Cameroon, but like talking about how to motivate employees or to help in the prevention part of cardiovascular diseases like stroke. Like here in America, some organizations have like, for example, like nurses where I work, we have like a card that you give employees sign up to like gym, like various gyms. Then you go there and then you sign that you log in today and you exercise. And then you have like incentives at the end of the month that you exercise. But I don't know how the system back home works. I think like big organizations, they can implement things like that. That way it encourages employees to go to work, to exercise. But because of the corruption, I know employees can go in and chip whosoever, the clerks there, and then they'll sign the paper. But that is you're harming yourself more than others. So another thing is about how prevention. I strongly believe in preventive care. I think that we can start at the lowest level, our own country meeting as individuals. We can say, okay, every month, we can just go in there and just educate our own people in our own common languages that the people will be able to understand, because sometimes when we use these medical jargons, they don't really understand. Like, for example, me, within 3 years, I've lost close family members to stroke. My dad had TIA, and they called us, said, oh, dad is talking, and sometimes he would not talk. They couldn't understand. I said, okay, this guy is having a TIA. He needs to go to the hospital. But they couldn't understand. But those education, I think that if we can start by just with our family members, our country meetings, things like that, before we start thinking about going to the public and stuff, that is, I think if we can start at that level, we can also help the general population. So that was what I was just trying to chip in, that as healthcare providers, we can also do that and help to reduce this risk and this mortality. Thank you.
Thank you so much. Very insightful.
Thank you so much, Yvette, for the contributions. Dr. Lekobo, if you don't really mind, I would like to take Fabrice Ngassong's question before we can wrap up. If you don't mind.
Yeah, sure.
Thank you so much for your patience. All right, Fabrice, over to you.
I hope they don't call me.
Okay, thank you. Thank you so much to all. And I'm Fabrice Ngassong, calling you from, let's say from Germany. And I'm very happy, to attend this meeting today. I have a small question. We are confronted with our local realities, and you know all that, okay? In particular, in the care of patients in our hospital suffering from all kinds of illness in general, and cardiovascular accident or stroke in particular. So I don't know whether you have thought about setting up kind of first aid units, which would not require a kind of fee to start healing patients. Because, you know, we used to neglect people who are not having money in our countries. And I don't know whether there is kind of, kind of hub or kind of thoughts about all those kind of situations. Thank you.
Thank you. If I may summarize or rephrase the question just for myself to make sure that I got it. So it's about being able to provide acute care to people even before they're able to have to pay for anything. Is that what you?
Yes.
Yeah,
you're right.
Yeah, that's a very difficult question to answer. Is it happening in some places? From my past experience, the answer is yes. And now in some of those confessional hospitals, once you get there, you don't have to get the money in hand to be taken care of. You get there, they take care of you, and then you pay the bill later. And some public hospitals are making an effort towards that too, but there are limitations. And it's the whole, like, how do we finance our healthcare system that's involved here? And really, it's not going to happen. I mean, it's not only about stroke, it's about everything, including acute care, stroke or anything acute. That's a question that needs to be answered by people sitting around the table and willing to do something. Are we going to wait for the government? Sure, the government can help. Are we going to organize ourselves, as one of our sisters mentioned, I forgot her name, as a community to try and help ourselves? Yes, I remember when I was in Bamenda Hospital, we came to put in place a system that allowed pregnant women to receive care no matter what before they could pay for it. And I can tell you, the families were so grateful that they will return and see the doctor with a big truck, with a truck full of plantain or whatever to say thank you. They didn't have the money right there, because when disease strike, you don't have money somewhere waiting to be sick. And that's what we forget. Here we have that caution, insurance companies, okay, that are there to save money for you to pay for you to pay when you're sick. So it is happening in some, locally in some places, including in Bamenda when I was there, where I used to deliver babies. I do CS section without every single penny being spent by the family beforehand. It's a matter of, do we want to do that? It's a matter of, can this happen to my sister, my mom? It's a matter of individual and collective responsibility. So people need to sit down and then realize that no one will come from heaven or from America and change the system. Okay, tough questions, I can tell you. Tough questions, but you have to be creative. You have to be creative. We don't have to copy what's happening in America or in the US or France, or we don't have to do that. We have to find a way to make things happen. What about you come to the hospital and then you put a plantain, maybe two big plantain or two big fowls or cow or goats, something like that. We have to be creative. And the poorer you are, the more creative you have to be to survive. Basically, if you have a nitrate that is stenotic, you have to develop collaterals. So we have to make sure that we use our brain to adapt our responses to issues to our context. It's not going to happen overnight. It will take time. We have to keep trying. I can take one more question before leaving, if you.
Luisa, can I?
Yes, you go ahead, Mr.
Doc, I see in the chat you have comments and questions. So Dr. Bill said there's one question about the physiotherapy that was not answered, the second part of his question. And Mr. Anji is asking about where can we localize the stroke center, the stroke unit in Cameroon, and what parameters will be used to determine an area with high percentage of stroke patients. I think here you answered about the teaching hospitals.
Yes, I said
if
that.
I'm
Yeah.
not wrong. Yeah.
Urban teaching hospital. I don't think there's any rural teaching hospital. Urban teaching hospital. It
Yeah.
starts there. It's like you saw a seed and then it just grow and blossom and people see it and then it just replicates over and over. You have to start somewhere. And for physical therapy, what was the physical therapy? The question about physical therapy, sorry, I missed that one.
So he was asking how early can we start the physiotherapy when we have a stroke
as soon as
patient?
possible.
And for how long?
ASAP. How long it depends. How long it depends. And usually the physical therapists are the one to determine how long they want to do it. They typically do it until you start plateauing, and then you say, okay, we stop.
And may I just ask, are there some contraindications for physiotherapy in a stroke patient, or?
You do it as much as the patient can tolerate it, basically.
Earlier the better.
There's
So
one
Luis,
question
I think we have.
Dr. Fonsa, I think that's an important question.
Okay. Yeah, we already in recent past have some dedicated wards for stroke at Saint Hospital Yaoundé in preparation for eventual stroke unit. This got unfortunately disturbed with reorganization of the pavilion. I don't know whether I
Okay,
missed
so
one.
we are trying. When I say we are, say as Cameroonian, we are trying to put in place things to make things change, and that's really what matters. It doesn't matter how many times we fail. If we keep trying, we get it one day, and I believe in it. The trying Yaoundé doesn't try. It should not be a matter of big professor or whatever. No. If I'm in Bamenda, I'm the director of the regional hospital Bamenda, and I have a young radiologist who's very motivated. I would say, okay, you know what? I'll give you 4 beds there. All your stroke patients, they go there, and I give you 2 nurses, and I give you someone else to help with that. And it starts there. Once they see the difference, they will start acting. And those guys, they will be willing to educate themselves, to learn, to be better. And everyone who comes there will see how this is how they manage stroke. And let's go to bingo and do the same thing, and so forth. It had to start somewhere. Don't wait for the government or what a big professor. I don't want to say that, but they're sometimes disconnected from the reality that we're living. They're important, very important, but they want to see you guys organized before they can help.
Thank you, Dr. Lekobo, for that reaction. And thank you again once more. Thank you so much for making out time to come and do this presentation for us. I don't really need to tell you how much impact it has. It's evident right in front of you how interactive it was here on Zoom and on other platforms where we go live during our presentations. We really appreciate you going on extra time more than scheduled. We're really grateful. But before we wrap up, we just want to go over and ask all the co-moderators and our chair to kind of give us one take-home message they got from this presentation. And I'm going to start with Brian.
Thanks, Louisa. I have no further comment. I just really wanted to acknowledge the presence of Dr. Julius Fonsa. I think he's one of the neurologists or one of the doctors at one of the stroke centers at the Central Hospital. I think he was there a couple of years back. I don't know if he's still there. Really appreciate his comments and remarks. I think this was a very insightful conversation and exchange, just a lot of feedback. So this really helpful. I really appreciate everyone for joining and definitely look forward to the next exchange. Thanks, Louisa. Over to you.
Thank you, Brian. So we'll go over to Grandse Allison.
Thanks, Louisa, and thank you again, Dr. Lekobo, for this great presentation. For me, I think what stood out is that, our systems are not perfect, but there's room for us to adapt the care to what we're able to do in our systems, versus just saying, well, we don't have access to this or that level of technology, so we don't do anything. So there's room for us to adapt to what works for us in our context. And, among all these factors that are risk factors for stroke, there are some that are truly modifiable. So we should also work on raising awareness and starting with ourselves around risk factors that are really truly modifiable. And that, it's important for these stroke patients to be in a hospital setting and to be well catered for, because once they've had the stroke, there's still a risk within that period. It's important that, catering for them in a specialized stroke center helps to increase their risk of, or the chances of survival. So thanks, Louisa, back to you.
Thank you, Alison. So today I was co-moderating with all of the senior co-moderators, and then myself and Christelle, who are the baby co-moderators. We were really out there today, sitting on the hot seat. Christelle, I'll give the floor to Dr. Foma to give his own points, then we can do the summary and get the last feedback from Dr. Allen, and we'll close today. Dr. Foma, over to you.
He's muted, I think.
Oh, no, my network. Did you call me?
Yes, I did.
I think my internet actually had a problem.
You're
Yeah,
muted.
so yeah. I'm sorry about yeah, my internet had a problem and I just got off. So I just want to thank Dr. Lekubo and thank everyone who is here today and for coming back all the time. The platform belongs to all Cameroonians. Our goal is to actually start conversations on healthcare issues in Cameroon. We want to provoke conversations. We want to stimulate the young minds to think about change, to start implementing things that we talk about in this platform. Our goal is not really to go implement it, but we know there are a lot of young minds here who can start change. And what I take back from this message is really a lot of things that Dr. Lekubo did not put the blame all on the government, as we usually do. Most of the time when you put it, it's easy to target one person and say, okay, the problem is the government, but who is the government? We are the government. A lot of us here have been directors in hospitals. A lot of us here are in charge of neurology units. A lot of us here are chief neurologists. A lot of us, the director of certain hospitals are themselves neurosurgeons, l'Hôpital Général. They are directors in many hospitals who could bring change at their own level. So I think this is thought-provoking that we talk about the government when we can make change. I don't want to talk as an individual. I saw how much power I had as a district in charge of a district hospital, how much I could change by myself. And I feel we can change a lot of things as individuals. It's not forgetting that policy is very important. So I love the fact that this responsibility was shared to everyone who was sitting here. And I also love the fact that he showed the example of what preventive medicine is. I too, being a public health specialist like Dr. Lekubo and being a clinician, I'm always torn between the two. It humbles me most of the time to know that for the past 100 years, even involving cancers or TB, before we started treating TB, the mortality from TB had already reduced by almost 50% from hygiene, sanitation, education, and many things. So the drugs themselves did not do much. A thought-provoking research in oncology in the 1980s showed that all our chemotherapies we're giving to patients were not making life better, which had to make us go back and reflect, which was thought-provoking because we had gone so far to think that what we're doing is really changing lives. So prevention is still very important. And I would applaud people in the town hall. If you have topics you want to discuss, if you know people who can come in and give us thought-provoking lectures and thought-provoking discussions about healthcare problems in Cameroon, please don't forget to let us know. Motivate them to come. We have a lot of people we're planning on inviting. I think Elvis is still, and Yahuba are going to get the minister for us one of these months. And please, you guys need to be very nice to the minister. So, okay, so over to you, moderators, and it's always wonderful having you guys, please.
Thank you very much, Dr. Foma. Thank you once again, Dr. Lekubo. It was really a pleasure for junior docs like us to meet you in person over Zoom. And thank you for the thought-provoking conversation that you gave. I want to especially thank all those who took out time to come to the town hall today. We really appreciate you coming out every time. It just shows that our efforts are going ahead and we're moving forward towards making healthcare in Cameroon better. So I'll just give a brief summary. It really pushes us on the hotspot to give a summary of what the professor has spoken or presented. So just a few take-home messages here. So his presentation was about stroke, and he did mention that timing is of the essence when it comes to diagnosis. Following his presentation, you'll see that risk factors for stroke, which are physical inactivity and hypertension, are on the rise in Cameroon. And we cannot say that stroke does not exist in Cameroon, because if you look at the data we had from 1999 to 2012, you see that there was an increase in stroke from about 2.5 increase in the incidence of stroke from about 2.5% to 13.1%. And when you look at the risk factors for stroke, which one of them is physical inactivity, and looking at our patient population or our population in Cameroon, which is a younger population, you see that it is possible to prevent stroke. And that's why he constantly insisted that we are all supposed to take charge in this stroke prevention. It's not a matter of the doctors, it's not a matter of the government, it is all of us. And he also went ahead to say, once someone has had the stroke, in case we didn't do the primary prevention and comes to the hospital, it needs a multidisciplinary approach in the management of stroke. And he went ahead to advocate for the need of a stroke unit. Again, studies have shown that patients who are managed under a stroke unit are more likely to survive than people who are managed with a stroke team, which is what we have available to us in Cameroon. And again, we don't want to wait until we get to the point of managing strokes. We can close the tap. So he therefore rests the responsibility on all of us. And with all the contributions from after the presentation, we all saw that we can all make an effort. We can go ahead and teach in our various small groups, in our village cultural groups, and just spread the word. As well as spreading the word from this town hall, we all have these recordings on YouTube, and we're going to share them via link using the email that you used in the email that you used to register for the meeting today. You'll get the YouTube video, and please share it as much as possible so that everyone can have access to this information. Thank you very much. Christelle, over to you.
Merci, Louisa. Merci infiniment, Dr. Lekoubou, pour cette présentation. Merci à tous ceux qui ont pu joindre cette séance d'échange aujourd'hui. Je vais me permettre de résumer en quelques mots toute l'information qui a été partagée aujourd'hui en français. Donc, il était question aujourd'hui de parler de l'AVC, et au cours de la présentation, Dr. Lekoubou a commencé par nous donner la clinique d'un patient, un cas clinique avec des patients avec des facteurs de risque, et il a insisté sur la nécessité de faire une prise en charge précoce, et puis enfin une action sur les facteurs de risque de l'AVC. Puis a suivi une épidémiologie où l'Afrique était représentée en rouge, en plus déjà des pathologies infectieuses transmissibles dont elle est victime. Il se pourrait que la prochaine épidémie soit les pathologies non transmissibles, parmi lesquelles les AVC. Et au Cameroun, déjà avec des données récoltées entre 1999 et 2012, on s'est rendu compte que la prévalence du taux d'admission avec des cas d'AVC varie entre 2,5% et pratiquement 13%. D'où l'importance de fermer les gaps. Et pour fermer ces gaps, 3 points ont été évoqués. Le plus important, la prévention. Au vu de la population jeune que compte l'Afrique et le Cameroun, entre 25 et 55 ans, il est important de mettre un accent sur l'activité physique, tant de manière individuelle, mais aussi dans les associations collectives et les milieux de travail. Mais aussi, il faudrait travailler à réduire la prévalence de l'hypertension artérielle dans la population. Et couplé au contrôle de l'obésité et de la dyslipidémie, on pourrait arriver à une réduction d'à peu près 80% des cas d'AVC dans la population. Et le deuxième point pour fermer les gaps était construire des unités de prise en charge spécialisées pour les AVC, où on aurait une unité neurovasculaire qui permettrait d'avoir un personnel formé dans la prise en charge des AVC, mais aussi d'avoir un soutien de la diaspora et de plusieurs autres partenaires, tout en créant un guideline local. Et enfin, il fallait penser au traitement secondaire pour les patients qui ont déjà développé un AVC et la réinsertion dans la société. Voici résumé quelques mots de cette présentation. Nous vous disons grandement merci d'avoir participé à cette nouvelle édition de Cameroon Town Hall, et au plaisir de vous revoir dans 2 semaines pour le prochain sujet. À toi, Chairman. Merci, Louisa, d'avoir co-modéré cette session avec moi. Ce n'est pas évident avec tout le talent et les connaissances venant de Dr. Lekoubou et de toute la foule. Nous sommes désolés si nous n'avons pas pu soulever tous les commentaires, toutes les questions au cours de cette édition, mais nous espérons que vous avez été largement satisfaits. Merci beaucoup. Merci encore. Dr. Foma?
Okay, thank you, everyone. We have the parking lot, which is 30 minutes after for discussions which will not be recorded. So I'm going